Hello everyone, we are here to discuss the Grand Test 182 dermatology questions. I hope you all have gone through these questions and you must have got them all correct. This 182 is also the PGI mock test. So the kind of questions that we'll see here will be the multiple choice questions, the way you get them in the PGI Chandigarh exam. Alright, let's begin. The first question for the day, which is otherwise question number 58 in your exam paper, is this. Please go through the question. This is asking us about Koebner's phenomena. It can occur in which of these conditions? We have 5 options. Multiple choice question. A lot of these conditions show us Koebnerization. Which are those? Let's go through this phenomena. This is your Koebner's phenomena. What is this? This is actually occurrence or appearance of new lesions at sites of trauma. This is how we define Koebner's phenomena. This is appearance of new lesions at the sites of trauma, which could be a scratch, it could be a wound, it could be an injury mark, whatever it is, a new lesion will appear at that point. This is seen in 7 to 14 days after the trauma. So that is the time gap. This is also important. You're supposed to know that within 7 to 14 days of the lesion, of the trauma, you'll see the lesion. And another important thing to know about Koebner's is, this is an all or none phenomena. Means, if a patient has a tendency for Koebner's phenomena, he will have new lesions appearing at all sites of trauma, irrespective of the type of trauma. However, if the patient doesn't have such a tendency, he will not have lesion at any site of trauma. So it is important to know that this is an all or none phenomena. And this is also an indicator of the activity of the disease. What does activity of the disease mean? If the patient is suffering from a current flare of psoriasis, there are a number of psoriatic lesions in the body has a tendency to develop new lesions. At that time, if there is a trauma, then there is a higher likelihood of it leading to a new lesion. That means Koebner's is also indicative of activity, severity of the disease. If a patient is on treatment, the disease flare is reducing, chances of a new lesion appearing at the site of trauma may reduce. So these are the 4 important points about this that you have to remember. Then, what disorders show us Koebner's? What disorders show this? Most characteristic is psoriasis vulgaris. This is the classic example of a lesion of Koebner's. Others include lichen planus and vitiligo. If you ask me, these are 3 disorders that should be by heart in case you have a question on Koebner's. However, for the purpose of such multiple choice questions, there are some other diseases which may show, may not show, it may be questionable to have Koebner's, but we have to remember them for the purpose of these multiple choice questions. Those include discoid, lupus, erythematosus, and erythema multiforme. 2 different instances of such a question in PGI. Apart from these 3 options, one question had this, the other question many years apart had this as an option. So please remember DLE and erythema multiforme as the other rare causes of Koebner's phenomena. Clear to everyone? I have a few photographs to show this to you in case you get an image-based question for the same. See, this is a patient of psoriasis. These linear erythematous scaly plaques present along the sites of scratching. Characteristic lesions of psoriasis may be present elsewhere on the body, but at the site of scratch we see such lesions. So this is classic Koebner's in psoriasis vulgaris. Okay, if such an image comes, I hope you can identify. Just notice these linearity of the lesions, right? Then we have lichen planus. If you look at this lesion here in this area, you can see these multiple lines along which we have the small purple colored papules. Classic purple polygonal papules of lichen planus present linearly along the sides of scratching. Absolutely characteristic Koebner's phenomena. Clear to everyone? So we've seen these two disorders. Classic lesions, vitiligo also you can have them. DLE, EM are the rarer causes. I hope this is clear. Then we will discuss what is also called as pseudo-Koebner's. Pseudo-Koebner's means lesions which happen due to auto-inoculation, seen in viral skin infections like warts caused by HPV and molluscum contagiosum caused by the molluscum contagiosum virus. Okay, these are two viral diseases in which we see pseudo-Koebner's. What is the meaning of pseudo-Koebner's? I have this big lesion here, right? This is my big lesion on the skin. Now, what does the patient do? The patient scratches along it. If the patient scratches and in the process of scratching, he abrades the epidermis downstream, small viral particles from the primary lesion will go and inoculate on the skin. So the viral particles which were there in this lesion here, they will get inoculated along the sides of the epidermal injury, and within a short span of time you will have these lesions downstream of the primary wart. So this is called as pseudo-Koebner's, seen in warts and molluscum contagiosum. Very important question. Please do not forget. Then there is another phenomena which is called as reverse Koebner's. What do you mean by reverse Koebner's? This is disappearance of the lesions after trauma. Such a nice thing for a patient to have. Patient has a psoriatic lesion here, he scratches and wow, the lesion disappears. So this is reverse Koebner's, disappearance of lesions after trauma. This is also seen in psoriasis. This is also a potential question. I hope this is clear to you all. Right? So when we come back to this question, now you have to tell me the answer. What is the answer to this one? A, yes. B, yes. C and E. So the correct options are A, B, C, E. Alright? Great. Now we move to the second question. Micro abscesses are seen in. What do you mean by a micro abscess? What do you mean by a micro abscess? This is a localized collection of inflammatory cells in the epidermis. So this is a localized, a small little collection of inflammatory cells, whatever it be. It may be a neutrophil, it may be a lymphocyte in the epidermis, any of the layers of the epidermis. So this is a micro-abscess. Now, what are the micro-abscesses that you remember? Where have you read them? Do you remember the Munro's micro-abscess? Potter's abscesses? Right. This is what are the micro-abscesses. So the important micro-abscesses that you have to remember are: 1, Munro's micro-abscess, and second is your Potter's abscess. Where are these seen? Munro's micro-abscess is a collection of neutrophils in the stratum corneum seen in patients of psoriasis. Potter's is collection of lymphocytes in the epidermis seen in a cutaneous tumor called as mycosis fungoides, also called as cutaneous T-cell lymphoma. Clear to everyone? Yes? Out of this, what is the question? The cell, the layer, and the disease. Very, very important question. Here also cell and the disease. Extremely important. Almost every year in some exam or the other, they will ask you a question on these abscesses or the histopath of psoriasis or mycosis fungoides. It is such an important question. So please remember Munro's and Potter's. Alright? Other abscesses that you need to know. One is Kogoj, spongiform pustules. What are these? These are collection of neutrophils in the stratum spinosum in patients of psoriasis. Clear? Second thing that we need to remember are the dermal, papillary tip abscesses. These are also made of neutrophils seen in patients of dermatitis herpetiformis. Okay? Clear? Question is on the type of cell, the layer of epidermis, and the disease. Here again the type of cell and the disease. So in these abscesses, important to remember not just the disorder but also the cell making them up and in which particular layer of the epidermis these are present. Clear? So what is the answer in this question? This and this. Clear to all? Moving on to the next question. Necrotic keratinocytes occur in which of these? For your purpose, at your level, if a question is talking about necrotic keratinocytes, then it is trying to ask you about interface dermatitis. This is what the question is trying to ask you. You're supposed to know the causes of this disorder. What exactly is interface dermatitis? Interface dermatitis is an amalgamation of three things: basal layer vacuolization, liquefactive degeneration of basement membrane, and third is a band like lymphocytic inflammatory infiltrate at the dermoepidermal junction. So these are the three basic components of interface dermatitis. Apart from that, it also has necrotic keratinocytes, which are also called as civet bodies. Clear to everyone? I think civet bodies would ring a bell in your mind because this you've read quite often. Interface dermatitis you've read quite often. The term necrotic keratinocyte actually confuses you. Had they just asked you interface dermatitis, maybe you would remember it better. So this we've studied. Now we come to the causes. What are the causes? Number one, you have disorders which are lichenoid disorders. In the lichenoid disorders, the most classic example for this is lichen planus. Then we have lichen striatus, lichen nitidus, and other lichenoid dermatitis. Then what we have are the drug eruptions. In the drug eruptions, it is erythema multiforme, fixed drug eruption, toxic epidermal necrolysis, and graft versus host disease. Okay, these are the most important causes. Then what do we have? We have some autoimmune connective tissue diseases like dermatomyositis and lupus erythematosus, right? These are the most important causes, along with some rarer ones like viral exanthems, poikilodermas. But if they have to ask you a question, the question will generally be on this, and this. Every cause of interface dermatitis is askable. Askable, actually, that is the term that I use. It's askable. Okay? So these are the important causes. AKA necrotic keratinocyte के cause और interface dermatitis के cause. Clear? Good. So what is the answer here? Answer is DLE, discoid lupus erythematosus. We read in the connective tissue diseases. Then we have graft versus host disease, erythema multiforme, and lichen planus. Clear? A, B, C, D. These are the causes of this disease. I hope I am clear to everyone. Moving on to the next question. Erythema, nodosum, leprosum can occur in. What is ENL? I'm sure you all know ENL. And where is it seen? This is quite an easy one. Leprosy reactions. In the leprosy reactions, we have a type 1 reaction, type 2 reaction, and the third thing that we have is Lucio phenomena. Okay, these are the three important things that we need to remember in leprosy reactions. Coming to type 1 leprosy reaction. This is generally seen in the tuberculoid pole, means BT or BB, which have low bacillary load, right? What happens here is a type 4 hypersensitivity response, extremely important. Type 4 hypersensitivity response, which means a cell-mediated immune response. What happens is you start treatment for the patient, generally happens after treatment, can also happen before, but you kill the bacteria. Bacteria are released from the macrophages, body identifies them, generates a hypersensitivity response towards the same, leading to clinical features like increased redness, edema in the pre-existing lesions. Along with that, new leprosy lesions and a lot of neuritis. These are the three most important clinical features. So how will a question describe? A patient complained of increased erythema and edema in his lesion on the face, along with which he also described multiple tiny lesions happening on the other sides of the body. Patient also complains of drooping of one side of the face along with drooping of saliva. If the lesion was in the hand, patient also complains of clawing of the fingers and sensory loss in the area supplied by in the area of the little finger or the ring finger. So this is how the question will give you. What is neuritis? Neuritis is inflammation of nerve. So this will cause loss of nerve function. It could be either a sensory loss or a motor loss. So this is also something that can be given in the question to you. Along with this edema, a new onset sensory motor deficit. Clear? This is slightly getting hidden. What I've written is a sensory loss or a motor loss. So this is your type 1 reaction. If we discuss about type 2 reaction, this is generally seen in BL and LL, which are your multibacillary or high bacillary load, seen in patients who have recently undergone a surgery or are pregnant, have increased chances. What is this? This is actually a type 3 hypersensitivity. Very important is this and this. Okay? Clear to everyone? Yes? And this is also called as ENL, which is your erythema nodosum leprosum. So now what exactly is ANL? ANL में there is no change in pre-existing lesions. You have eruption of multiple erythematous, tender, evanescent nodules which resolve in 48 to 72 hours and appear in crops. This can be associated with fever, arthralgia, uveitis, orchitis, lymphadenitis, neuritis, hepatitis. Basically all internal organs can be involved here. Very, very important. Very important here. Important to remember is erythematous, tender and evanescent. Disappear in 48 to 72 hours. This is the most important point that you have to remember. Clear? And the sites on which it appears commonly are face, upper and lower limbs, and abdomen. These are the most important sites. Okay? Apart from the associated features. I hope this is clear to everyone. Then what is the third one? That is your Lucio phenomena. This generally happens in your LL leprosy, where there is extremely high load of bacteria. So much so that the bacteria are seen in the vascular endothelium of the capillaries and arterioles. Like this is your capillary. The bacteria will be present here, and once the bacteria are present here, due to which the blood vessel undergoes necrosis, leading to necrotizing vasculitis, which leads to ischemia of the skin, leading to ulcers. And it is quite severe, it is almost fatal. Very difficult to rescue a patient from Lucio phenomena. How is it given in the exam? A patient came with purplish discoloration of the leprosy lesions, followed by ulceration, associated with severe fever and constitutional symptoms. What is the diagnosis? What is the histopathology marker? In which type of leprosy is it seen? Everything in front of you right here. So this is very important. Very important. This. Clear? Yes? Good. I have an image of ANL here. See, these are the nodules which appear in crops. Such an image can also be given in the exam along with a description. So identify the type of lesion here. These are all nodules. Okay? Give me the answer. The answer here is A and B. Alright, borderline leprosy and lepromatous leprosy. What is the treatment for ENL? Most important point is continue MBMDT. Secondly, if it is a mild reaction, give NSAIDs. If it is moderate to severe, start oral steroids, most commonly prednisolone, at the dose of 40 mg per day. Okay, this is also the treatment of choice. Oral corticosteroids. What are the other drugs that you can give? Increase the dose of clofazimine 200 mg TDS, or give thalidomide 200 to 400 mg OD. Okay. Some other drugs include pentoxifylline, zinc, methotrexate. I hope I'm clear to all of you. Treatment of ENL is very, very important. You have to remember that the drug of choice is oral steroids. In some old textbooks, the older questions, thalidomide may be given. But please remember, thalidomide is not the drug of choice. It is not the treatment of choice. Thalidomide is only given if a patient is not responding, resistant, or highly dependent on corticosteroids. So this is a secondary option. Never my primary option, never my treatment of choice. Please remember this. And important side effects of clofazimine, thalidomide also you have to remember. Clofazimine is reddish brown discoloration of the skin and xerosis. Thalidomide, most importantly, teratogenicity, phocomelia, sedation or insomnia, sleep disturbances, constipation, peripheral neuropathy. These are the three most important side effects of thalidomide. Then other than this, other uses of thalidomide: multiple myeloma, HIV-associated aphthe, recurrent oral aphthe, Behçet's disease, other types of vasculitis. These are the uses of thalidomide. All of these are potential questions. How does thalidomide work here? Thalidomide works here due to its anti-TNF alpha action. Okay, this is also an important question. Right. The last question in this GT is this one. We've just discussed micro-munro's abscesses, so I'm sure you can give me an answer to this one. We've just discussed it. Seen in stratum corneum, in psoriasis, and it contains only neutrophils. We just discussed. So I'm sure this is an easy one with you. But using this question, I will like to discuss the histopath of psoriasis. Histopath of psoriasis is so important every year, every alternate year. One of the exam, PGI, AIMS, NEET, DNB, whichever of these will have a question on HPE of psoriasis. Whenever we discuss a histopath, it's always good to start from the top or the bottom. Proceed in an order, you will never forget it. So, starting from the top, this is how we will discuss it. these are the important points of histopath of psoriasis. And mind you, all of these are questions on their own, multiple choice, all except. Either way, every point in histopath of psoriasis is important. And in the AIMS exams, they may just give you an image, like this image, and ask you, what disease is it? Okay, so histopath can be also asked as an image-based question as well as a text-based question. Coming to the text, these are the points that you have to remember. Parakeratosis, which is present of nucleated keratinocytes in the stratum corneum. Munro's microabscesses, as we've discussed, neutrophilic collections in the stratum corneum. Hypogranulosis, most classical example of a disorder showing decreased or absent granular layer is psoriasis. Acanthosis means increased thickness of stratum spinosum. Kogoch pustules, I will tell you, we've already discussed, but we'll just remember your neutrophils present in stratum spinosum. Then broadening and elongation of rete. Regular enlargement and broadening of rete, classical cause psoriasis. And I'll also show you how it will allow you to recognize a case. Coming to dermis, suprapapillary thinning, dilated capillaries and lymphocytic infiltrate. These two are the causes why you see Auspitz sign. Auspitz sign. This is also a question. Why do you see positive Auspitz sign in psoriasis? It is because of a combination of these two factors, suprapapillary thinning and dilated tortuous dermal capillaries. Now, just look at this image. Just look at it. What is the first thing that you notice? The first thing that you notice are these rete. They are so, in a normal epidermis, they would go like this. However, here they are going like this. So this is the change. Classic cause psoriasis. At your level, only cause. Such an image in the exam, you cannot go wrong if you identify these classic points. Broadening enlargement of rete. Other thing that you notice is this purplish color in the stratum corneum. These are your parakeratotic cells, nucleated keratinocytes in the stratum corneum. I hope you remember that stratum corneum is a dead layer. All cells are anucleate. But in psoriasis, you see parakeratosis. Acanthosis is there. Your stratum spinosum is thickened. Spongiosis in neutrophils can't see in low power. Another point that you see here is suprapapillary thinning. These are the points showing suprapapillary thinning. Okay? This is your dermal papilla. Supra is thin as compared to this point. So this is suprapapillary thinning. Lymphocytes here. These are all lymphocytes. Clear to everyone? Can you now identify this image as psoriasis if you get it in the exam? This was asked in the AIMS exam 2017 November. I have another image, is this one, the low power image. Parakeratotic cells, these are the parakeratotic keratinocytes in the stratum corneum. Then these few cells here are your neutrophils forming the micro-munro abscesses. Then these spongiform lesions can also have lymphocytes leading to the Kogoch pustules, dilated capillaries, and lymphocytic inflammation here. Okay, so this is a low power image giving you the details. I'm sure after this you can answer all questions on HPE of psoriasis. All the best for your exam. See you in the next discussion.